All right, let's dive right in. Today, we're putting together a really practical, step-by-step clinical workflow for managing insomnia, something you can use every single day in the pharmacy. We'll cover everything from patient assessment and behavioral therapies to the key counseling points for the meds you're dispensing all the time.
So, here's our game plan. We're going to start with the foundation, how to properly assess a patient and set the right goals. Then we'll cover why behavior is always king before we even think about pills. After that, we'll get into the medications, the classics, the new kids on the block, and we'll wrap up by looking at how to handle those tricky cases in special populations.
Okay, picture this. A patient walks up to your counter and asks for something to help them sleep. Now, before your brain even jumps to a product, what's your next move? This single question right here is what turns a simple sale into a real clinical consultation, and that's exactly where we, as pharmacists, need to be.
So let's build on that. Before we can even suggest a solution, we have to figure out what we're actually treating. I mean, is this just a couple of bad nights because of stress, or are we looking at something more chronic and ingrained?
For it to be diagnosed as chronic insomnia disorder, it's got to meet these specific criteria from the DSM-5. It's not just, I have trouble sleeping. It's about a pattern. We're talking at least 3 nights a week for at least 3 months straight. But honestly, the most important piece of this puzzle is the last one, the impact. It has to be causing real, noticeable problems in their daily life.
This chart is a fantastic roadmap for your conversation. For us in the pharmacy, those sections on behaviors and daytime consequences, that's our sweet spot. This is where we can dig in and ask the important questions. So, tell me, are you scrolling on your phone in bed? How many coffees are you having, and when's your last one? And, most importantly, how are you feeling the next day?
And that leads us to this, which is honestly a total game changer. Our primary goal isn't just stuffing more hours of sleep into the night, it's about making the patient's daytime better. This is such a powerful counseling point. When you help a patient shift their focus from I need to get 8 hours to I just want to feel human and have energy during the day, you completely change the definition of what a win looks like.
So if the main goal is to improve daytime function, that brings us directly to the most important part of any treatment plan. Before we even think about writing a prescription or recommending a product, the foundation has to be built on non-drug strategies. This isn't just a nice idea, it's first-line, evidence-based care.
And the gold standard here is something called cognitive behavioral therapy for insomnia, or CBTI. It's built on these 5 core pillars. It's all about teaching patients to retrain their brain to see the bed as a place for sleep, not for worrying. It's about cleaning up their habits and, crucially, challenging those anxious thoughts like, oh no, if I don't fall asleep right now, tomorrow's going to be a total disaster. Long-term, this is way more effective than any pill.
Now, these are the practical, everyday counseling points you can hand out. And look, while sleep hygiene by itself might not cure chronic insomnia, it's a non-negotiable part of the plan. The power here is in the details you can give them, like aiming for that cool room temperature, between 16 and 20 degrees Celsius, or really hammering home that rule. The bedroom is for sleep and intimacy, that's it. No work, no TV, no scrolling. But of course, there are definitely times when medication is needed. And when it is, the drugs we see the most are benzodiazepines and the so-called Z drugs. Let's really break these down, because while they're related, they are absolutely not the same thing.
Okay, so both of these drug classes work on the same receptor in the brain, GABA A, but the Z drugs are way more selective. They're more targeted. And that selectivity is what gives them a much better side effect profile. You get that same sleep-inducing effect, but with a lower risk of dependence, way less muscle relaxation, and, this is a big one, they haven't been shown to make sleep apnea worse, which is a huge concern with traditional benzos.
When you're counseling on Z drugs, you have to be specific. For zopiclone, the big things to mention are that common bitter or metallic taste, you want to warn them about that, and the full 12-hour restriction before driving. For zolpidem, the driving warning is a bit shorter, at 8 hours, but it's absolutely essential to stress that lower 5 milligrams starting dose for women because their bodies clear it more slowly.
Now this right here is probably the single most important safety warning for any of these drugs. The combination with alcohol is an absolute 100% no-go. The source says it should be repeatedly stressed, and they're not kidding. This combo dramatically increases the risk of some really scary stuff, like sleepwalking, sleep eating, even sleep driving. It is a non-negotiable counseling point every single time.
All right, so let's move beyond the traditional players.
The world of insomnia meds is always changing, and we're seeing newer drug mechanisms and a lot of off-label use in practice. So it's really important for us to know what these are and why they're being used.
So a great example of a new approach is this class, the dual orexin receptor antagonists, or DORAs. Instead of acting like a sledgehammer to sedate the brain, these drugs work more subtly. They block a chemical called orexin, which is basically the brain's wake up signal. The result is a much more natural transition to sleep, and it comes with some huge advantages, like no evidence of that rebound insomnia when you stop it, and we have data showing it works for up to a year.
This table is basically your real-world clinical cheat sheet because you are going to see these drugs used off-label all the time. The secret is to understand the rationale. It's about matching the drug's side effect profile to the patient's other conditions. Got a patient with depression? Trazodone or mirtazine might make sense. Someone with fibromyalgia? Gabapentin could be a good fit. Our job is to be on the lookout for those key side effects like next-day grogginess or weight gain.
Okay, now we have to talk about how our entire game plan changes when we're counseling specific groups of patients. The whole risk versus benefit calculation gets turned on its head, especially when we're talking about the elderly and patients who are pregnant.
For our older patients, the #1 priority is safety. We want to reduce the risk of falls and fuzzy thinking at all costs. That's why CBTI is, again, the absolute first choice. If we have to use a medication, we're reaching for safer options like very low-dose doxepin or limberexant. And look at that list on the right, the agents to avoid. Critically, that includes over-the-counter antihistamines like diphenhydramine. They are just not a good choice in the elderly because of all their side effects.
Now in pregnancy, we have to be even more cautious. Once again, what's the treatment of choice? CBTI and sleep hygiene education. If medication is absolutely unavoidable, after a serious risk-benefit discussion with the doctor, some sources suggest agents like zopiclone or trazodone might be considered. But notice what's on the avoid list. Benzodiazepines are a concern, especially in the first trimester, and zolpidem has been linked to some negative outcomes.
So, to wrap this all up and bring our whole workflow together, it really comes down to this one simple but powerful question. When you're talking to your patient, are you helping them chase some arbitrary number of hours on a clock, or are you helping them achieve what really matters, a better, more functional, more enjoyable day? Framing the entire conversation this way doesn't just manage their expectations, it completely redefines success. Thanks for watching.